It is my honor to introduce our next speaker, Dr. Santhosh Menon, who will talk about the risk of cardiovascular complications in South Asians. Dr. Menon is an MD, FACC, FHFSA, a cardiologist specializing in heart failure. He is, among many other positions, a staff cardiologist at Ohio Heart and Vascular Center and director at the South Asian Comprehensive Cardiovascular Center at the Christ Hospital in Cincinnati. Dr. Menon started his medical education at TD Medical College in Alapura, India, where he was also part of the college cricket team. He did his residency and internship at Robert Wood Johnson Medical School in New Jersey. On behalf of Red Saree, I would like to thank Dr. Menon for taking the time to speak with us today. If you have any questions for Dr. Menon, please do post them in the chat box, and we will have a short Q&A session after the presentation. Now, Dr. Menon. Dr. Menon, please take it away.
Thank you very much. My video is not starting. I think you have to start it, but that's fine. Shakti, can you bring up my slides, please? Excellent. So I want to thank all of you for having me, especially the Red Saree organizers. This is a wonderful organization. I'm going to talk to you about, you've heard this again and again, why are we as South Asians at a high risk for heart disease? Next slide. I'll start off with a true story. SM is a 46-year-old South Asian male, actually my wife's first cousin. He called one Saturday saying he was having nausea, shortness of breath, and the funny thing is he was sweaty, he just didn't feel good. He didn't know what he thought it was something he ate. I told him, go to the local hospital in Columbus, Ohio, which is about 2 hours from here, and get checked out. Well, it seems he was having a heart attack and he received 2 stents within his coronary arteries. His risk factors at that time, he was a little obese, mild high blood pressure, no family history, does not smoke, does not exercise much, and no diabetes. And his lipids, which he told me later, that was drawn 3 months ago, showed a total cholesterol of 190, LDL of 108, HDL of 32, triglycerides of 250. Now, these numbers may not make sense to you, but this is a typical South Asian where the HDL is low, which is protective. The LDL is not that high, which does not raise any alarms, but the triglycerides are very high. So young person, South Asian, having a heart attack, not an uncommon story. Next slide. Well, this came to forefront in the New York Times by the MASALA study, which someone had mentioned. Two researchers, one from UCSF, one from Northwestern, looked at over 1,000 patients in the Bay Area and Chicago, followed them for several years, looking at what was causing them, what was the demographics of heart disease. It was an NIH-funded grant, and really it came to the forefront as to how we as South Asians at such high risk for heart disease. Next slide. Well, what is the problem? We'll go back to MASALA in a second. You've probably seen these numbers before. We make up 25% of the world's population, but we account for more than 60% of the world's cardiac patients. And heart disease is the leading cause of death in India, Pakistan, Bangladesh, and the rates continue to rise as the rates of diabetes and obesity continue to rise in these countries. We are, as they had mentioned, from the fastest growing ethnic groups in the US, and by 2023, we will probably be number 3 in terms of the ethnic minority in this country. But here's a problem. When compared to the US population, South Asians living in the US, a risk of heart attack is 4 times the normal US population when you look at risk factors. We'll go over that. And this heart disease is 4 times greater, and it starts 10 years earlier than our counterparts in white Americans. And once we have a heart attack, our risk of dying, that is mortality from a heart attack, is about 40%, whether we undergo stenting or bypass surgery. And just because we migrate to the US, we think we get better care and access to better care, the risk does not mitigate. Next slide. Well, what is the problem? Here's the crux of the problem. This is where all the action happens. This is a cut section of an artery. The way to look at it is that the body has one long artery, whether it starts in the heart, in the neck, the carotids, or in your legs. It's just one artery. What you see in the yellow is the plaque buildup. That is due to risk factors such as a family history, maybe genetics, having diabetes, obesity, lack of exercise, builds up the plaque and towards the right. And over that, the plaque ruptures and causes a blockage, and that gives you a heart attack. That is the crux of the problem. It is no different in whites, South Asians, Chinese, and so on. It's just our risk factors are much more accelerated. Next slide. Well, what was the MASALA study? It was a great acronym. Mediators of Artherosclerosis, South Asians living in America. Again, 1,100 patients, NIH funded, and they enrolled from 2010 to 2013. And they want to find out, why are we having heart attacks and cardiovascular issues at a very early age? And what they found was that South Asians have, as I'd mentioned before, 4 times risk of cardiovascular events, occurs 10 years early in white counterparts, and the higher mortality from heart attack, as I mentioned. Well, what were the causes? What they found by doing CAT scans, we have increased adiposity, that is fat accumulating. I'll show you some slides on that. Increased diabetes mellitus at an early age. And we have this thing called insulin resistance, where if you're obese, your insulin does not work, which reduces glucose, and that's a big problem. And body composition, again, I'll show you some information on that. And there's possibly a genetic component. Right now, there's no genetic component. This was not an interventional trial. This was just a demographic trial, enlightening us as to what is our risk and when does it happen. They also showed that we develop plaque earlier, on, as I'd shown you before on the plaque cartoon, in the carotid arteries, which cause stroke, and in the heart. Next slide. Well, why does this happen? Why does it happen to us? But as I'd shown you that slide of the artery, the plaque is the same as it's seen in white counterparts as it is in South Asians. But the problem with us as South Asians is increased prevalence of known risk factors. Insulin resistance, suggesting inflammation. That is what is type 2 diabetes and metabolic syndrome. Metabolic syndrome means obesity in the gut, low HDL, high triglycerides, and hypertension, which is very common among South Asians, whether they live in the South Asian countries or they migrate to US, Canada, Britain. And type 2 diabetes is almost of epidemic proportions in South Asian countries, and that has been translated to the US. There are 120 million South Asians, will have it by 2030. That is 23% of the South Asian population, whereas only about 6% in the Caucasian population have type 2 diabetes. Our HDL, which is protected, it protects the plaque, is low uniformly, and that goes along with type 2 diabetes, obesity, and everything. We have elevated Lp(a), which is a marker, which is actually a subparticle within lipids that is a sign of inflammation. That can have a genetic component to it. We tend to have typical high triglycerides and a low HDL, and I'll show you a little bit of information about that. And here's a problem: the obesity. Most of our obesity hides in our stomach, in our gut. And I'll show you some CAT scans of that. And our BMI, body mass index, is lower and does not meet obesity standards, does not meet aggressive therapy, and that's where the shortcomings of some of the measurements are. We also have lack of physical exercise. The MASALA study showed that we walk about 2,000 feet less than our counterparts. And as we become more successful, as we become CEOs, professors, and all that, we are much more sedentary. We have a higher incidence of high blood pressure, and as you know, high blood pressure is a risk factor for heart disease, stroke, and so on, and it's much more dangerous for us to have high blood pressure. We also have a lot of inflammation. I'm not talking about inflammation in your joints, but in the arteries, and that is seen by elevated homocysteine level, CRP, and that is probably related to our diet and our type 2 diabetes. And there still has not been a genetic component for this for South Asians. Next slide. But here, and we have the perfect storm. We have all the risk factors, but when we go to see our doctors, especially if it's a non-South Asian doctors, our cholesterol levels, as I'd shown you in my wife's cousin, does not raise a red flag. Well, it doesn't look too bad. You don't need treatment. You're not obese, so on. Our BMIs are lower. But if you use the BMI criteria by the American Diabetic Association, we don't meet the obesity criteria for more aggressive therapy because our fat hides in the gut area, and I'll show you CAT scans of that. And again, and then if you use a risk calculator, as you know, we all use risk calculators to calculate your risk. South Asians are undercalculated. So if you use a calculator, your doctor will say, well, you don't meet criteria for aggressive therapy, you're fine, we'll see you in a year or two. And a lot of times we have a little bit of high blood pressure and the sugar diabetes, and it goes untreated because our doctors are not aggressive enough, seeing that we're thin and our cholesterol is not that bad. It's just not treated, and that causes problem over time. A lot of us are vegetarians for religious reasons. Americans and Westerners become vegetarians for health reasons, but I'll show you actually vegetarianism is not protective. And the MASALA study, people showed that compared to a diet that includes South Asian as well as Western diet. And also the biggest thing, which many of you talked about, is cultural barriers to getting appropriate and early care, language issue, ride issues, insurance issues, and just inhibition of seeing doctors, especially non-South Asians, prevents a lot of these people, especially the elderly, from getting care. Next slide. And this is not something we're talking about in the fringes. You guys have been talking about it for a while, but the American College of Cardiology's front page in one of the journals handout was about South Asians and the cardiovascular risk. So this has become mainstream, and I'll show you some of the guidelines that have changed because of all this data. Next slide. Well, what am I talking about fat distribution? In South Asians, our fat is in the middle and to the right, the moderate to high risk. It hides in the belly, the yellow stuff, and you can't see it because if you do the BMI, it will not capture that you're obese. It's only by the waist-hip ratio, which is what I do in my clinic, which is much more accurate in South Asians. So you see a South Asian, he looks thin, he's got a little bit of a paunch belly, not much muscle, typical. You think they're not obese, so you don't have to treat them. You don't have to treat the diabetes, but the fat hides in the viscera, as we say it, as you see on the rightmost highest risk. Next slide. As you can see, this is a cut section of a CAT scan. You're looking from the feet up. The white stuff is your spine, and those are the kidneys around it. What you see is that all the black stuff on the right is all fat. Whereas in white Americans, you see our counterparts, in the left side, the fat is outside, it's just below the skin. So they tend to have bigger bellies. Our fat tends to hide inside us. And that is actually more what we call artherogenic, meaning that's what causes plaque formation in the coronary arteries and worsening diabetes. Next slide. And this is a typical picture, as you can see. And these patients tend to be diabetics, insulin resistant, hypertensive, and sedentary, and this is what is the nidus of the almost epidemic proportions of coronary disease in our South Asians. Next slide. So again, just going back to body mass index, among South Asians, we have the highest obesity ratios, but we develop insulin resistance at a lower BMI. That means that in whites, they tend to be much bigger people, much more obese when they develop insulin resistance, or what we call type 2 diabetes or metabolic syndrome. But we develop much earlier, and that leads probably to why we develop coronary disease much earlier. And because of that, they had the WHO in 2002 changed recommendations that obesity is lower. Before it was above 25, now they've dropped it to below greater than 24. To say that you're obese, so that a lot of the South Asians can be captured and have aggressive preventative treatment. Next slide. But then our diet is a big part of the problem. Next slide. We do enjoy our meals very much. It is a connection to our homeland. Next slide. But here's a problem with the South Asian diet. As someone had mentioned, is high in carbs, low in fiber, because we tend to overcook our vegetables a lot, and that takes the good nutrients out of it. Now, I'm not a dietitian, but this is what I have learned. It's high in saturated fats, high in sugar, and as you know, sugar is converted to fat when the body can't use it, and that is put into your belly and into the arteries and stuff like that. And we think that because we're vegetarian, it protects us from heart disease when it actually doesn't. But the problem is that a lot of times, a lot of my patients, it's difficult to talk to about diet, changing diet, because it is a bond to our culture and homeland. Next slide. And also, as we become more successful in this country, as we rise the corporate ladder or wherever, or academic ladder, we tend to become more sedentary, which again elevates all the other risk factors. Next slide. Next slide. So what about psychological factors? I mean, especially with this COVID era, mental stress has been shown in the MASALA study to play a big part at work and at home. Depression, especially because it goes undiagnosed in women. Women, like many of you said, are the keystone to a lot of families, but they're undertreated. They don't get care. And I've seen in my office, and I'm sure many of you have seen this, a lot of times the wife comes, who's my patient, and the husband does all the talking for them, which is really a bit of a problem. And they don't get care. They don't get the depression taken care of. But if the mother goes down, the whole society falls apart. The whole family falls apart. Also, psychological factors: lack of social support, protective social factors. They get isolated. Access of barriers to healthcare due to location, transportation, cultural issues, insurance issues, and also language issues play a big barrier to getting care. And psychological factors increase your risk of heart disease. Next slide. That's just a tip of the iceberg. Next slide. What about the risk factors are not predictive? Just because you have the risk factors doesn't mean you will get heart disease. And sometimes you need more information to kind of convince your patients or your colleagues that you need something more done. Next slide. Well, what can you do? You've heard all this information. What can I do to reduce my risk factors? Well, first of all, see your doctor. Get your lipids checked. If they're high, get the subparticles done, as we mentioned, the LP little a and all that, which is a separate test. Get also markers of inflammation, the CRP and the homocysteine levels. We think those are very important. But also get your sugars checked. Get a non-invasive imaging test, and I'll show you some examples. Start exercising. There is no downside for us to exercise. And regular exercise, whatever will get you moving is good. Studies have shown 6 months of intervention. Saheli has shown in Chicago, 6 months interventions led to better blood sugar control, better blood pressure control, better mental status in terms of depression and anxiety, just with a 6 month intervention. You have to exercise. You don't have to go to a gym, whatever works for you. And there should be a couple of days of weights and resistance training for bone buildup. Very few Indians smoke, but if you do, you're just adding to your problem. Lose weight. Again, find out what is your ideal body mass index or your waist-hip ratio based on the charts. And you got to change your diet. You have to increase fiber, reduce carbohydrates, especially simple carbohydrates and sugars. It's not impossible, but you can do. As I told you before, the best diet, the studies that shown that the best diet that work are the ones that straddle a little bit of Western and a little bit of our native diet, mixing the two together. Any way you can increase your legumes, fiber, and so on, talk to a dietitian. Reduce stress, difficult, but not impossible. Meditation works, as you emphasize. Exercise works. Talking to other people really helps. The isolation is a bad thing among South Asians. Alcohol intake, again, high sugars that can increase your blood sugars, and we have a high risk for cirrhosis. But this kind of treatment has to be tailored to you. It's not that one formula works for everybody else. Some require some other type of therapies. Next slide. Exercise, again, I cannot emphasize more. We need to spend less time sitting, especially now with COVID, we're working from home. It's very important. 30 minutes a day, 4 or 5 times a week, and then resistance exercise is very good for you. And I think that there are cultural barriers to exercise, especially for women, which there's a lot of different ways of overcoming, having exercise groups and so on. Next slide. As you can see, we'll lift for samosas. Anyway, next slide. What is the benefits of exercise? First of all, I tell my patients there really is no downsides unless you get hit by a bus or something. It helps prevent diabetes, helps reduce weight. If you reduce your weight to ideal body weight, you reduce your risk of diabetes by 20 to 30%. Improves muscle mass, which is very good. Our muscle mass is low, so our body's not able to store the protein compared to white. It helps manage stress. It lowers blood pressures, improves the HDL. Not by that much, but something is better than nothing. It helps strengthen bones, and you become a role model for your kids. We're talking about second generation immigrants to this country, but we also have to talk about our kids too, who are just as high risk, and they need to learn about healthy living. And one of the ways is by seeing you exercise, and they will do what you do. And it also probably delays aging. Next slide. Well, what can you do? What else can you ask your doctor? Get a calcium score, and I'll show you some picture. Calcium score is looking at plaque in your coronary arteries, and studies have shown it comes much earlier in South Asians when compared to whites. So it's a marker that you have inflammation, that you have plaque. You need aggressive therapy. Then get all the blood tests done. Get on a statin. Really, there's no randomized studies in South Asians, but we think that statins are quite beneficial in terms of reducing inflammation and protecting the plaque. And it takes 5 years of taking a statin therapy to get its benefit. So taking it for 6 months, there's no benefit. You got to have a long-term plan for this. Control your blood pressure, exercise, control your diet, control stress. Again, to emphasize, it has to be tailored to you. Next slide. Again, this is a coronary calcium score. This is, again, looking up from the feet up. It's the heart in the middle. The white stuff you see on the right in the heart itself is calcium. That is plaque. And you get a calcium score that tells you how much plaque burden you have. And I tailor my therapy based on that. It's a very simple test. It is a CAT scan. It takes about 7 minutes to do. No IVs or anything like that. Next slide. Again, coronary CT is a very fancy angiogram of your heart. I do that in some of my patients, but that's a different study altogether. Next slide. Again, statins are safe. My time is running, so I'm going to go through this quickly. They are liver is followed. Liver abnormalities are very rare, does not cause dementia, and it does help reduce stroke and heart attacks over time. Next slide. Again, what are the future directions in this? Outcome studies. There are no outcome studies in South Asians. And AHA is changing lipid guidelines to include South Asians, as has the American Lipid Society. American Diabetic Association has done the same. Clinical trials specific for South Asian, specialized centers. Again, what you guys are doing, awareness, local, nationally, Red Saree, that is what's worked, as you know, over time. The American Heart Association was based on education before it became a thing for doctors and everything. It was based on educating people about the risks of heart disease. And it has to be culturally specific guidelines. Risk calculators, there are none that are for South Asians, but they're building on those. You can't extrapolate from what we use in white Americans. The diet has to be tailored, exercise has to be tailored, possibly genetics, as Shakti is looking into. And again, the public policy about Representative Jay Paul, if it gets passed, would be great. I mean, that is the way, that be similar to the way Go Red is so successful in educating women about the risk of heart disease. Next slide. Really, but then after all this, some of us are really immortal. If you don't know, left side is Wasim Akram, the bowler from Pakistan. And of course, Sachin Tendulkar and Amitabh Bachchan, they'll live forever. But the rest of us, we are mortals. We have to do everything to protect ourselves and our families. And I think and this is a very important saying, as you know, health is wealth. We never know our value until we lose it. We all know family members or friends who have had heart attacks at an early age. This can be prevented. We just have to increase the awareness, which is what Red Saree is doing. Thank you very much. I'm happy to take any questions.
Thank you, Dr. Menon. Everyone, looks like the chat box is not up. So if you have any questions, please do unmute yourself and go ahead and ask questions. While we wait for the questions, I actually have a question, Dr. Menon. You mentioned inflammation, and that is something that I've heard about in past webinars in Red Saree also. Now, I don't think measuring the inflammation is part of a regular blood work panel, correct? Is that something that we have to ask the doctors for?
Yes, good question. Yes, the ones that you should ask for is homocysteine level and CRP. Now, the problem is that if you have a cold, your CRP will go up. Okay. But there are very good indicators, I think. And the problem is, what do you do with them? Yeah. I think that exercise, weight loss, controlling diabetes, and statins reduce these markers, and they're protective. I think they did an interventional study with homocysteine with vitamin B12, no benefit. But I think it's good to do. The more information you have, the more you can empower yourself to take better care. But I think only in South Asia, because in whites, you don't see such a high increase in inflammation.
Right. Anyone else? You mentioned exercise. Any particular guidelines saying how much of exercise, what type?
Yeah, I mean anything that gets you moving. Walking is good. You got to sweat it a little bit. Strolling is not very good. Remember, for
Right.
every hour you sit, you should walk for 5 minutes, because sitting is the new diabetes. We all sit at Zoom, on calls and everything. It is the new diabetes. And as we get older, we think that we have to walk less, exercise less. That is absolutely not the case. So anything gets you moving 30 minutes a day, 5 days a week. And then along with resistance training, that is, resistance bands, a little bit of weights, it's a win-win. And your kids will pick up the same habit. Sitting is the worst thing we spend a lot of time educating ourselves, educating our children, but this kind of stuff is just as important, because once you have a heart attack or a stroke, the horse is out of the barn. You're already in trouble by then.
Dr. Menon, that was a wonderful presentation. So my question is, people have high blood cholesterol level. That's kind of normal for a lot of South Asians. But when they have a normal blood pressure, should they again go for statin, or is there what's the strategy for taking statin?
It depends. For example, in my practice, if a South Asian comes, is a family history of heart disease at an early age, that's what a lot of them come because of that, or they have diabetes, or they're obese, I will push hard on the diet for one, and then try again 6 months. And if they still are not good, I would recommend a statin. And a lot of people are hesitant to do that. They need more evidence. So sometimes what I get is a calcium score. And someone above 50, because that's when this calcium starts building up, or just vascular screening. They need more evidence. Doing a stress test or an angiogram is not a good idea in patients that are asymptomatic, but I tend to push the statins a little earlier. Now, remember, we have an enzyme deficiency that makes us a little more sensitive to statins. So you have to remember half the dose of what they give white Americans. And then, I also recommend coenzyme Q10 to my patients, because that reduces side effects of statins. But that is, like I said, it takes 5 years to get that protection and to reduce inflammation, to prevent plaque formation. So I tend to push it a little hard.
Thank you. Anyone, you can unmute yourself if you have any questions to ask Dr. Menon.
I have a question. This is Hi, this is Rama Kasturi, and I have a question. What is the target HDL level that you'd recommend for South Asians, given their abysmally low levels, like you said, is an issue? So what should be the target, and is too much HDL a bad thing?
Good question. It is very difficult to get your HDL up. Maybe maximum with statins and real aggressive weight loss and exercise, you'll get it up by 10%. Normal men should be above 45, women above 40. But the young females, premenopausal, tend to have in the 60s and 70s. But you can't really get it up that much. Now, maybe the newer injectable cholesterol-lowering medications do increase it, but none of the statins really increase it that much. But you really have to drop the weight. You drop the weight, it'll come up. You exercise, it'll come up. But there's a plateau. You can't double your HDL. I've never seen that before. And your white counterparts, especially women, I've seen them in triple digits. Some of them from no exercise, nothing. They're genetically protected, I think, some of them. But the thing is to treat the underlying problem. Just putting on medication won't work. Niacin has never been proven to work. So you have to exercise and reduce the weight and really watch your diet. And it's not impossible. A pound a month, if you lose, you get to your ideal body weight, you reduce your risk of diabetes and heart disease by 20-30%, which is an incredible number without any medication.
So there is no upper ceiling for an HDL. There's no such thing as too much of a good thing with HDL.
No, the highest I've seen is 100. They say there's some data that it maybe increases risk of intracranial hemorrhage a little bit when it's that high. But I've not seen it. I mean, like I said, some people genetically, like people from Sicily, are genetically protected, and Mediterraneans, because of their diet, long-term genetics, as well as the very active people. Theirs are in the 90s and 100s, even when they're in the age 90. they're protected, you know.
Well,
especially if you don't have.
There's one question on Facebook that I would like to read. We can have this as a last question. What are your thoughts on using statins in Southeast Asians with the normal lipids over age of 50 as a precaution?
The data has never supported that. I would use it if you were a diabetic, if you had a significant family history, but I would need more data to put you on it. Something like, you know, a vascular screening or a calcium score. We don't randomly put patients. We don't put patients on it unless they have abnormal lipids or they have significant risk factors. I've rarely seen a South Asian, obviously my population is skewed, who has normal lipids. They all tend to have some, unless they are, some of them are, you know, with very few, some of them marathon runners and all that. Even then, I've not seen very high HDL levels. I've seen low LDL level, as we had mentioned, but the triglycerides tend to be high. So I tend to look at then lipid subparticles, LP little a, which can be driven down by statins, we think, or by one of the injectable medications, which, as you know, reduce your cholesterol significantly. Injected once in 2 weeks and no statin. They're amazing drugs, but it is an injection. But randomly, no. Just because you have it, there's no benefit whatsoever.
Dr. Menon, this is Kishore Kalikiri. So I'm a bit off on the other end of the spectrum where you mentioned about walking. So I have averaged about 17,000 steps per day this year. So close to hitting 6 million steps by end of this month. Is there too much of that walking that could, I guess, affect another way? So, you know, my friends are mocking me now that, you know, I'm just hell-bent on walking more just because of this COVID situation, you know, I don't want to sit at home. So I'm walking once in the morning during, 30 minutes during lunch and then evening again. So I just want to get your thoughts on it.
No, hats off to you. Any exercise that will keep you motivated, keep you moving is good. Okay. Now, I've seen in some of my white patients, these ultra marathoners in their 60s and 70s, they started having heart issues, even though they have completely normal cholesterol, just because of overuse of the heart. No such thing. Movement is key. Our ancestors, they ate this South Asian diet, but they walked a lot and they were exercised a lot. We eat the same stuff, but we don't exercise much. I think our downfall is our lack of exercise in our diet. I think those are two things that we can easily fix. Whatever gets you motivated, I would not recommend going to a gym right now. Absolutely not with this COVID stuff. But going outside and walking, wonderful. I mean, keep it up. That's admirable. But everybody has to have a plan to sustain this, whether you buy a treadmill, or for the winter months, or not make excuses not to exercise. It's easiest for us to make excuses not to exercise. But I'm telling you, if you do it, everything will fall in line, I believe. But you can't exercise and then go to McDonald's and eat a Whopper. I mean, it negates everything. You got to do both of them. And with diet, you don't have to really become very vegan or anything like that. There's no benefit to that. But just controlling everything, especially the South Asian stuff. And one day a cheat day is perfectly fine, but you have to increase fiber in your diet along with exercise, along with stress reduction, things like that. And everything will fall into place. It'll become a habit. You won't be able, it's days you don't walk, you'll feel worse. You feel like you missed out on something. So hats off to you. I mean, that's a very good motivation.
Thank you.
Okay, that we can end this session. Latha?
I had a question. Is that too late?
No. Oh, I mean, it's up to you guys.
You can ask, yes, please.
Go ahead.
Okay. Hi, my name is Uma. So the issue I'm having is doctors. So my lifestyle is pretty good. Like I exercise at least 90 minutes every day. My weight is in the normal range, so my BMI is good. But my LDL has always been high, like 200 or whatever. But my HDL is good. But my doctor always argues that I'm a very low risk for statin. How do you convince your primary care physician that South Asians are high risk, or we have to look beyond these numbers a little bit?
Ask him. No, that's a very good question. Do you have more?
That's my primary question. So my dad died of heart attack when he was 38. So I feel like I'm very high risk for heart disease.
Yeah.
So, and I'm constantly battling this, saying, when I go to him, it's like, hey, I don't see any risk for you. Your A1C is good, your HDL, you work out so much, look at everything else except your LDL. It's okay. It's genetic. You can't influence it. So the thing is, Dr. Menon, and you touched upon in your presentation, I even if I eat right and I do everything, I can only control it to like 20 points max over the last 7 or 8 years that I've seen. So I've not been able to control my LDL with natural stuff, and I'm not on statin yet. So how do you convince your PCPs?
I'm talking to the American PCPs how to handle South Asians. One thing is that, if you're near about 50 years of age, we tend to get a calcium score. I tend to, because that'll tell me if you have plaque. If you're below 50, you'll have soft plaque, which will not be seen on a calcium score. Another thing is vascular screening. The simple stuff that they do, they look at the carotid plaque in the carotid arteries, which the MASALA study people showed that you get plaque early in South Asians. And it looks for aneurysm and things like that. That'll give you more evidence. I don't start everybody on a statin. You are, in the top 1% that you exercise, you eat right. I mean, there's no guarantee, but if you can ask your doctor, well, what about a calcium score or some vascular screening, which you can do on your own. You don't need a doctor's order for that. But I'm a big fan of those because those show up very early in South Asians. And then if you have even a little bit of plaque, I tend to be very aggressive in terms of reducing the LDL cholesterol with the statin. Because you're not just reducing the LDL cholesterol, you're reducing inflammatory markers with the statin. And that is what causes heart attack. When you have a lot of inflammations, as I mentioned, such as homocysteine and CRP, you are what we call thrombogenic. That's basically you have a chance of building up a clot when the plaque ruptures, and that's what causes a heart attack. So the statins, benefits are bimodal. That is that they reduce cholesterol, yes, but they stabilize the plaque. But you have to have plaque to stabilize. If your vascular screening is 0 and your calcium score is 0, your risk of heart attack is less than 1%. And what I do in my patients is 5 years later, repeat another calcium score, see if there's any plaque buildup. So someone is watching this stuff all the time. But I think I would ask your doctor, what about a vascular screening or a calcium score?
Uma, that answered. Okay, looks like it.
Muted, yeah. Sorry, we are running out of time. Thank you.
Okay.
Yeah. Thank you, Dr. Menon.
Okay.
Dr. Menon, thank you so much. That was a really wonderful presentation. We would like to have a separate session just only for you.
Yes.
Sure, anytime. You guys are doing a wonderful job. Keep it up, okay? We need more like this, so well done.